Hi, everybody. We're going to go ahead and get started. We have, I think, two more presentations before we close out for the day. And I'm going to go ahead and introduce our next presenter, Dana Langford from Village of Healing Circle. Dana M. Langford is a Cleveland native. As a certified nurse midwife in previous experience as a women's health nurse practitioner, her expertise initiated and expanded while working in Albany, Georgia, and St. Petersburg, Florida. She returned to her roots in Cleveland, Ohio. While working as a certified nurse midwife and serving on numerous committees, she observed Black women were not being heard in the discussion of racial disparities in maternal and infant health. She co founded Village of Healing, a community development organization focused on healing and empowering the village to eliminate social determinants of health and decrease disparities. Under that umbrella, the Village of Healing Center was developed to deliver quality health care that meets the social and cultural needs of patients. She founded Dana M. Langford Consulting, an enterprise focused on uplifting communities and addressing systemic injustices through education, professional coaching, and advocacy. Through core competencies in nursing, midwife coaching, and community education with cultural sensitivity, this uniquely positions the organization to empower clients to provide specific, evidence based evaluation and to implement customized consultations. With a host of experience working in hospital systems as a certified nurse midwife for more than 13 years, Dana is invested in serving the Black community. She brings clinical bedside and corporate boardroom experience, coupled with an adherent passion for the eradication of racial disparities to her companies and the communities she serves. Through her numerous speaking engagements and serving as a mentor to professionals and students, a preceptor to nursing students and advanced practice nursing students, she has committed her career to serving, educating, empowering, and advocating for Black women. Please welcome Dana to the workshop.
Thank you so much. I don't speak with the microphone. My voice carries, but I guess for everyone else, so it probably will be even louder on the cameras. But I'm so honored, privileged, and blessed to stand before you today. I'm always embarrassed when people read my bio and people tell me to stop doing that. But I just thank you guys so much for having me here to talk about Village of Healing, the Village of Healing Center, what we are doing for the Black community in Cleveland, Ohio, and our innovative work and our new model we're incorporating called our pediatric model. Yep, I think so. Oh, maybe not. Okay, there we go. So, learning objectives for today to understand the racist history of obstetrics and gynecology that has created the mistrust of Black patients. So, with this first speaker, I was like, no. But I always start with that because you would be surprised at the number of people that when we present Village of Healing or we're in conversations about Village of Healing that ask me and my partner, well, why do you need a center focused on Black patients? And so we always have to talk about and examine the racist history, especially in obstetrics and gynecology, that has brought Black women to a place where we are choosing home birth, especially because we are afraid of the traumatic experience to be in hospital systems. And then to be introduced to the Village of Healing Center, a culturally sensitive care, and the services that we offer, and then to discuss the innovative approach of the pediatric postpartum model to be implemented at the Village of Healing Center. So, of course, as a Black woman, I always have to justify why I belong to stand up here, why I am considered as an expert in my field. If you are a Black woman, you understand that wholeheartedly, that sometimes you have to justify why you are asked to do the things you are. So, just a passion for serving the underserved populations. Host of experience working in hospitals. That number is up to 15 years now as a certified nurse midwife. I practiced down south in Albany, Georgia, St. Petersburg, Florida, before returning home to Cleveland, Ohio. professional advocate specializing in the theory of evidence-based practice, committed to serving, educating, empowering, and advocating for Black women. I always say I am very pro-Black. It does not mean that I am anti anyone else. The best story and analogy that I've heard is that our one of our board members, our board secretary, Angel Jacobs, says, I'm at a basketball game, there are two teams playing. My team at the start of the game is down 50 points. It doesn't mean that I wish ill will on your team, but I got to do a whole lot of cheering to even get my team to zero. And then co-founder and CEO of Village of Healing and the Village of Healing Center, president and CEO of Dana M. Langford Consulting. And I believe we as a community have our own answers. Just trust us to implement those answers. So how do we get to a place of mistrust in the Black community when it comes to obstetrical and gynecological care? There's a couple different examples, but Anarcha, Lucy, and Betsy, as she touched on earlier, in the 1840s were three enslaved women that were leased to Marion Sims, who in our center, every room is named after a Black person in history. Our three exam rooms are named after Anarcha, Lucy, and Betsy. We purposely have left Marion Sims off of his name, off of that description. The reason being is because he is now known as the father of modern gynecology, even though these three women's bodies were sacrificed and used in order to get to where we are in gynecology. He has now gotten statues. He is known as the father of modern gynecology. He's currently in textbooks, but these three women continue to go unnamed. And so we wanted to be purposeful when we created our center to make sure that we acknowledge these women as the mothers of gynecology. But in the 1840s, these women were leased to Marion Sims and their bodies. They had deliveries, traumatic deliveries that had caused all type of trauma to their bodies. And so Marion Sims, this white physician from outside of Alabama, said he had this great miracle suture stitch procedures that would help. And so the slave masters at the time had decided, okay, we need these women to get back to work. It wasn't about their healing, it wasn't about their bodies, but just get back to work. We need you back in the fields. So he leased these three women to them, and they ended up going with him for his care. So the experimental operations of the women, of course, came with no consent because Black women were not people. They could not give consent. They were gawked at in the OR by white physicians who were watching Marion Sims as he practiced on them because they wanted to learn from this masterful man as well. And there was, of course, no anesthesia because, again, it was believed that Black women didn't experience pain the same way as white women did. They were restrained to the table so that their involuntary movements from the painful procedures would not stop him from being able to perform what he needed to do. And then some documented as taking as long as 1 hour to do. And then sometimes, of course, afterwards, they developed infections in their recovery and they spent days in extreme agony and pain, again, without pain medicine. Also, I wanted it to be noted that it took over 5 years for him to perfect this stitch in this procedure. In these 5 years, of course, the other physicians that were subbing in as his assistants were not able to just stay there and wait for those 5 years, so they left. So who did he turn to now become his assistants? But those same Black women. So Anarcha, Lucy, and Betsy were the three that were actually named in his works. So they would actually watch this trauma happen to their sisters. And then at the same time have to stand beside him, take care of them when they were recovering in agony and pain, and then on their turn, then come into the rotation to assist him. So Michelle Browder, who has started her own museum in the actual place that these women were tortured. So she's actually taken that site where they were tortured and is now opening a center for that community in obstetrics and gynecology. And she has beautiful statues that she has created, and now she does an annual conference in Alabama. She said, when you look at the experimentation that has happened to Black women and Black people in general, and to know some of the findings was from the torture of these people and to be overlooked the way it has, it's imperative that we change the narrative of healthcare. And then, of course, I always have to talk about the systemic eradication of the Black midwife in my own profession. One of the darkest moments in U.S. history was the systemic eradication of the African American midwife from her community, resulting in a legacy of birth injustices. Shafia Monroe is a quote from her. So, in the early 1600s, the slave trade brought African American women who were trained and practiced as midwives over on the slave ships. Black midwives were the primary source of care and birth for all families down south, Black and white. We refer to these midwives as the granny midwife. It was an apprenticeship learning opportunity. Grandma, great grandma taught grandma, grandma taught whoever else wanted to, and this is how you learned. Some stories that I've read when I visited the African American History Museum talks about women learning or young girls learning as young as 14 years old in apprenticeship style how to deliver babies in that time frame. In the mid 1700s, obstetrics was introduced to America, and America was like, thank you, white men. We love this. And so in the early 1800s, the upper and middle class white American, the white male physician replaced the midwife. The way that it was done was as that the white male physician and the white female public health nurse literally took out ads in papers saying that Black midwives were dirty, incompetent, and full of infection. They also put out wanted ads for Black midwives if they delivered for their arrest and for fines and fees, because they wanted to show that obstetrics was the new way, that we should be practicing obstetrics and gynecology. The white male physician was the answer. However, what we also noticed during that time, was that infant and maternal mortality rates continued to rise. And it was much lower when the Black midwife was delivering. However, in that rise, the white male physicians and the white female public health nurses said, oh no, it's really these dirty, Black, incompetent midwives. They should have to go through a special training in order to continue to practice. Of course, in the 1700s, Black women and Black people weren't even allowed to read or write. So how could we sit and go through a formalized training? The public health nurses, like I said, joined the obstetricians in a campaign to eliminate the traditional midwife. In pregnancy, they said it was a dangerous condition requiring care available from only highly trained medical specialists. I think that bullet point is so hilarious because I still think today that is the conversation. If you sit around in grand rounds or as a nurse midwife, I remember sitting on the floor for a report. And this is exactly the message that is still delivered to this day, is that you have to have a doctor. And so we're finding out, and we know as midwives that that's just absurd, and that you have a better outcome when you do have midwives involved in your care. And doctors have a place. I will say that. I'm very quick to throw my hands up and be like, sister girl, let me tell you something. This is beyond what I can do for you. And so I think at this point, we need to bring in a doctor. The midwives' clients were mainly poor women. And however, the obstetricians and the public health nurses had also decided during this time, we need to be able to practice our craft and we need to be able to practice what we do. And so we need those poor patients. And so we have to gear up on this thought process and this marketing that the Black midwife is not needed and that she is dirty, and make sure that we get her out of here. So we need these poor people to practice on. And again, we see that today in resident clinics, which are usually found in the poor neighborhoods. And then midwives attended approximately half of all births in the 1900s, but less than 15% by 1935. So the end result, the hospital birth attended by an obstetrician became a symbol of middle-class achievement. And today, the Black midwife accounts for 5 to 8% of all midwives in the country. And that includes nurse midwives and CPMs. So what are Black patients and their experiences in healthcare? Our past and present experiences with racial discrimination shape the interaction with medical providers. In other presentations, I talk about the problem we see in wealth, the problem we see in the criminal justice system, the disparity we see in employment, the disparity we see in education. Everywhere we turn as Black people in this country, there is a system and a systemic injustice and a systemic racism and institutionalized racism that is faced against us. And then we say, now walk into the hospital system and accept whatever care they give you. And so inside the healthcare system, what we know exists are barriers to timely and affordable healthcare, lower quality maternal health care services, disrespectful treatment, and untimely negative medical outcomes. So how do Black patients benefit from this culturally sensitive care? Reproductive injustices experienced by Black patients are manifested in disrespect, humiliation, verbal abuse during childbirth, coercion for unwanted procedures, inadequate pain medication, violating privacy, and negligence. I remember being in hospital rooms as a nurse midwife and literally watching the nurse snatch the patient's ankle to bring her down to the bottom of the bed, snatch the arm or hold a patient down and say, oh, that's not necessary. You don't need to do all that screaming. Of course, you're having a baby. It's going to hurt. This is what happens. Or even after they have an epidural, when they're saying, I'm still feeling everything. Well, you having a baby, everything is not going to go away. This is the treatment that is experienced in the hospitals. Studies have shown that Black patients have better health outcomes and routinely agree to more and more invasive health tests and interventions when they're seen by Black physicians, and they're more likely to choose a provider of their own race, ethnicity, increasing the likelihood of seeking needed health care. This in turn creates an environment that promotes health and addresses chronic health care needs. The study where they have the better healthcare outcomes and routinely agree to more invasive, that's what we talked about earlier, where it's not a lack of a commitment, it's a fear of retaliation. And so while I'm in there, I'm gonna do everything in my power to root and take care of Black people and even to be an advocate. However, if I go too far, I have to now face, I'm aggressive, I am all of the things. I'm angry. There were so many meetings that we left out and they were like, I just can't understand why you were just so angry. And all of that, did you think all of that was necessary? Well, you were so aggressive. I feared for my safety at some point, just for me saying, why is this the treatment that we're doing? And so as Black providers in healthcare systems, this is what we face every day. And so again, we get a greater respect, greater trust for the provider, provider competence, provider empathy, more inclusive communication, greater birth satisfaction. And so from that, my partner and I, Tanisha Gaines, we co-founded Village of Healing and the Village of Healing Center. Village of Healing is the large umbrella. It's community programming focused on decreasing racial disparities and improving outcomes. Under Village of Healing, we have 2 community programs right now. Our Mother to Mother program, where we take moms that are currently going through maternal mental health complications, pair them with moms that are in recovery from maternal mental health complications, and it's a peer-to-peer support. They decide what that relationship looks like. Some of our moms just do texting. Some of our moms go to court with other moms. Some of our moms go to the house to provide some respite and relief. They just decide what that in all looks like. And I'm very, very loose with the term mental health complication. Because if you ask me as a Black woman, every Black woman suffers from at least PTSD. If it's just from turning on the news every day to watching for the next killing or going on social media to watch what's going on in our own communities. Under this umbrella, the Village of Healing Center was born. Cleveland, Ohio was found to be the worst place to live if you were a Black woman in a study in 2021, I believe. Second to last in healthcare outcomes. Cleveland, Ohio also has world-renowned Cleveland Clinic, where kings and queens fly in for care. It is literally about 15 to 20 blocks in the inner city of Cleveland. It is a gorgeous city until you make the wrong turn, and then you realize exactly where you are. But those areas surrounding Cleveland Clinic have the worst outcomes and highest racial disparities for Black people. And so for our city to be found to be the worst to live for Black women, it was an outrage. It was, oh my God, this can't be true. Even the other 2 large hospital systems in the city are all located in the inner cities of Cleveland, whereas Black women were sitting at the tables like, I could have told you that. I got my own stories. We could definitely have that conversation. And so we also were in the process of reading studies that talked about when your provider looks like you, your healthcare outcomes are better, your disparities decrease, your satisfaction is better, and you're giving more informed consent. And so We followed the data, which is what we're always told. What does the data say? And we created the Village of Healing Center, which is a whole healthcare center focused on Black providers taking care of Black patients. So the mission of the center is to deliver quality healthcare services that meet the social and cultural needs of patients, improving health outcomes and quality of care that eliminates racial and ethnic health disparities. Our vision to offer all members of the community healthcare that looks like them. Very simple. So why a need for the Village of Healing Center? This is where everything else now comes into place. We talked about the racist history of obstetrics and gynecology. We talked about Black people's experience with healthcare. This is all playing a part into why the Village of Healing Center is needed. It's recognizing that racism leads to the racial disparities we see in healthcare and the increased morbidity and mortality rates. It's recognizing the evidence that supports Black patients feel harmed and unheard. And it's addressing ongoing efforts to improve quality and access to care for Black women. So the services that we offer right now, we have a nurse midwife, myself. We also have a licensed professional counselor. We've just hired a psychiatric nurse practitioner, and we're adding a family nurse practitioner all by January. Right now, we offer obstetrics and gynecology, prenatal care, postpartum care, gynecological care. With our prenatal care or an obstetric care, the women decide which hospitals they want to deliver at. We do not have a birthing center yet. The birthing center, freestanding birthing center, is going to be created by Birthing Beautiful Communities, our doula organization in Cleveland, Ohio, and that is set to open in 2025. And so we are in conversations with them as well. As we do a lot of work together, we just recently received a $1.5 million grant to work together to look at what care looks like with a Black midwife, a Black doula, and a Black community health worker. But in the meantime, until that opens, you pick and choose which hospital you want to deliver at. You do get a doula. About 99% of our patients take doulas, and it's a team-based approach. We all talk to each other. Literally, as I got off the plane yesterday and cut my phone on, there was a doula on the phone like, I got a patient I'm worried about. And so we talked, we came up with a plan together and then called the patient on three-way. And so sometimes it's just better when you know that you have a team of people that are working to make sure that you're safe and to make sure that you're healthy. And then our mental health services that we offer include all of the above. We usually she sees women and men over the age of 18. However, we also do some teen pregnancies. And so she very much steps in for those, and we get them signed up for care immediately. And then so what we found is that we started reading some studies that showed that people weren't showing up for their postpartum visits. And we were starting to notice the same, that, you know, they were gung-ho at prenatal care. They were there more than I was there for prenatal care. And then postpartum care, and they were like, I mean, it's out now. I'm okay. I don't need to keep following up. And so we were trying to figure out what could we do to create this, this same excitement for your postpartum care. And so the recommendations, of course, say visiting an obstetrician and primary care providers. The new, talk that we're hearing about is that if you have a higher risk pregnancy, including preeclampsia, gestational hypertension, gestational diabetes, you should be following up with primary care within that first year. Well, my patients, it's hard to get them to follow up with primary care without pregnancy. Like, I literally have people coming in for hemoglobin A1Cs in the 15, and they like, I'm fine, no, I'm here. I don't need to follow up. And so we're having those conversations and trying to figure out what do we need to incorporate. So we then read some research out of Johns Hopkins, which data that was collected in Maryland. It looked at one commercial insurance plan and then multiple Medicaid insurance plans. And they found the Medicaid insurance plans, 56.6% of those with a complicated pregnancy and 51.7% of those without a complicated pregnancy actually visited a primary care provider within 1 year. For the commercial insurance plans, it was 60% with a complicated, 49.6% without a complicated. It also found that white patients, older patients, and patients with depression or preeclampsia were more likely to visit their primary care provider. And so we also noticed during this research, the postpartum visits within 3 months, the Medicaid was 65% of those complicated pregnancies, 61.5% without complicated pregnancies, And where we were really, really shocked, and this was our own biases, right, as Black women especially, commercial insurance, 50.8% of those with complicated pregnancies, and only 44.6% of those without complicated pregnancies. So we had to really sit down and have that conversation. And then it was very easy because as we were having the conversation, I was 1 week out from surgery from a rotator cuff repair, back at work working. And my doctor was like, please just go home. Just don't do this to me. And what we found and what we realized is that especially as professional Black women or those that have commercial insurance are feeling like, I gotta get back to work. If I don't get back to work, I'm gonna be viewed as lazy. I'm going to be looked over. I'm going to be looked down on. And so I have to get back to work. And I think that that's across the board. A lot of times with women as a whole, we feel like we have to get back to it because we don't want to be viewed as being the mob. And so in conclusion, the Johns Hopkins research said providers need to develop creative ways to improve attendance to postpartum visits. In the same study, they talked about Johns Hopkins Bayview Medical Center starting a pilot project with a combined mom-baby visit, include the baby's checkup and the mother's visit. Mother may be more likely to keep the appointment and receive all of the education and follow up with primary care. So we heard and we listened, which is what I love about Village of Healing. I don't have to do 19 meetings about the first meeting before we decide if we're going to move to the next meeting to apply for the grant in the next meeting. Literally, we heard Black women when they were crying and coming into our appointment saying, I need help. We brought in a mental health provider within 1 month. Within 3 months, her schedule was completely full. So again, we heard women that were like, I don't have time to keep coming in here for these appointments. I got to get over here for my pediatric appointment, come here for this appointment. I done took off of work for all of them. And so what we also noticed is that as we worked in hospitals, hospitals were weld oil machines where if you open the door at the bottom, none of the parts are working together. And so the machine looks great. It looks shiny. It looks like it's doing exactly what it's supposed to do till you open the door and you're like, ooh. And so I even noticed myself because I had a great relationship with a lot of our pediatricians that I could find out what was going on with baby, or they would call me and say, your mom was in here today and she just did not look well. But nobody else had, a lot of us didn't have that relationship, and we were literally in the same building. They were on floor 1 and we were on floor 2. And so we were missing a lot. And then our own evaluator, I always give her credit, was going through something one day with her own friend who had just recently delivered. The baby was in cardiology. The mom was having severe mental health illness, was admitted involuntarily. And so she's taking the baby to the cardiology appointments, and the doctor is like, well, tell mom to, and she's like, mom is in your hospital, involuntarily admitted, and you don't even know this. And so she was like, I just don't understand why they just don't do appointments together. Why would mom and baby just not be in the same appointment? And so I was like, that's a very good question. And so we built our peds and postpartum model. And with that, it's designed for access, affordability, and better health outcomes. Again, we talked about, Cleveland being found the worst city for Black women. And so we wanted to try to find a model that would make it easier, that would make it convenient, that would be preventative. What we found is that when people were coming for their 2-week appointment, we were catching a lot of postpartum depressions and anxieties, a lot of postpartum preeclampsias. And so we were like, why are we not do them together? And so we wanted to be preventative in that way. And then Medicaid data reports 6 appointments in the first 15 months of life produce better health outcomes. And so what we'll have is we'll have our family nurse practitioner, our midwife or women's health nurse practitioner will see patients on the same day at the same time. And that way it'll be a team-based approach. When they walk out, it's not, they told me this, they told you that. We can all come together, figure it out. And if we need to then involve mental health in that, we'll do that as well. We'll meet once a month for families we think need it, sit down at the same table and figure out with a community health worker, does this family have every resource it needs in this first year of life? This does go quick. Okay. So we adding it to the Village of Healing Center, of course, with our vision of culturally sensitive care, provides access to that culturally sensitive mental health, primary care, and everything else. And I always say, we used to say holistic spelled with an H. Then we were getting people coming in making acupuncture appointments and sea moss appointments. And I was like, I'm not your girl for that. But so when we say holistic, we mean the whole entire woman. My thought process is always Black women are the CEOs of our families. And so how do we ensure that this Black woman is at her highest, healthiest, thriving self so that it trickles down to the rest of the entire family? So our goal, 1 year after delivery, moms and babies, like we said, sees the midwife, the women's health nurse practitioner, and then also bringing in the family nurse practitioner to be the pediatric provider also allows the mom to meet a primary care provider in that same appointment and realize and get comfortable with that primary care provider and then make that appointment that we need them to have within that first year with the primary care provider. Mental health providers are added, monthly team meetings. And again, by doing this, we reduce the cost and time barriers for patients and improve medical and mental health outcomes for families and infants. Our objectives, and these are still, okay. The crazy part is when I did this, it was very like crisp, and my executive admin was like, this is a nice crisp presentation. It almost looks sterile. And I was like, absolutely not. That is not me at all. So I jazzed it up. But 90% of women and infants who deliver in 2024 will see our family nurse practitioner and midwife or women's health nurse practitioner team for 6 postpartum well visits. 90% of infants will receive all recommended immunizations and care. 100% of women receive medical and mental health evaluations, and 90% of women and infants will complete 6 postpartum pediatric visits in 12 months. This is still very much fluid. We brought in an evaluator, and so they're going to start on day 1 in January. So they had some different thoughts. You know, if you work with scientists, they like, yeah, that's cool, but we could do better. And so they're still saying some things that they would like to add to this. But overall, these are our objectives and our outcomes that we want to see. Any questions or comments? I should probably say too, I did not put the outcomes of the center. We just completed our first fiscal year, June 30th. So for that fiscal year, we went back and looked at all of our results. We saw 463 women in our very first year. We had over 1,100 visits. We had 19 out of 21 full-term births. So we were under that 10% preterm birth rate. Those 2 preterms came in June. I was like, no. Those 2 preterms came in June. However, one of them had a cerclage placed, and the only reason she agreed to have that cerclage placed is because Village of Healing had a conversation with her. She walked out of university hospitals as soon as they said, we need to place a cerclage. She was like, absolutely not. I do not trust you all. She called us from the car. We had a long conversation with her. She trusted us enough, walked back in there, got that cerclage placed, and she was able to get to 27 weeks pregnant. And she now has a healthy baby boy that she brings with her just to have conversations and talk with us in the hallways. And so we've had some really, really great outcomes. We're super excited. We also have implemented something called Clap Out. I saw on a commercial one time where cancer survivors get to ring a bell. So what we do is for when they make it to 37 weeks, we ring a bell, we all come in the hallway, and we clap that mom out to congratulate her on making it full term. So, any questions, issues, concerns? I said the same thing. I'm like, I don't need that mic.
So where are you located?
Okay. So we are in Cleveland, Ohio, but we're in a suburb called Euclid. So here's what we know. Cleveland is, I think the last time I heard, number 4 on the list of most segregated cities in the country. There's an east side and a west side, and it's all separated by a river. On the east side, we have the worst disparities. We only have 2 delivering hospitals. On the west side, I believe they have 4 or 5 delivering hospitals, and of course, the best disparities. So I'm going to let you decide which is which side Black folks live on or which side everybody else lives on. And so we are on the east side because that's where we're needed. We chose a suburb called Euclid, Ohio, and the reason we chose that suburb is because it had the most freeway access. for all the surrounding suburb cities, but it also had the most bus access so that we could make sure that we were serving lower and higher socioeconomic status women. We know that socioeconomic status is not a protector for Black women when it comes to infant and maternal mortality.
You're in a standalone, sorry. You're in a standalone building.
Yes.
Okay,
We're in
thank
a
you.
standalone building.
Does the clinic offer at-home visits? for
Not
postpartum?
yet. It is definitely on my list of things to do. And as my list continue to grow, my partner is like, just stop for 1 second. But it is definitely on my list of things to do, especially for postpartum. I think that we miss a huge number of people, especially within that first year. We know that preeclampsia is the number one reason for Black women, but mental health is the second. And so just doing a pop-up visit on a mom, we could probably find out a lot in that home. A lot of times I think, especially as Black women, we know how to pull it together and to walk into a space and trick everybody that we have it together. And so I think those home visits really, really help. Anyone else? Yes.
The how we start trying to, work together. She said Black doctors. I think you kind of said the same thing. Do you have any other suggestions? Like I don't plan on becoming a doctor ever, right?
I'm
But
like,
I'm really, really big on community work. So I'm just trying to get some ideas as to how I'm from Kansas, KCK, as to how to just get more involved in my community and get the information out there.
So I think, Black providers, increasing the pipeline of Black providers into the healthcare field is great. As she said, less than 3% of Black providers in obstetrics and gynecology are Black. Less than 5% across the board of physicians are Black. You saw midwives 5 to 8%. I think nurse practitioners in general is about 5%. So right now, there's only so much we can do, right? So my other thought process is, besides increasing that pipeline, is getting the community involved. So your Black doulas are huge. I can do nothing in my job without having doulas present. I remember walking into birthing rooms, and like she said, when a Black patient had a doula, it was, oh, they're gonna be complicated. How you know that ain't her auntie? Because they used to say doulas had to be a plus one. They couldn't be a part of the staff or team. So we fought to change that because the conversations were, that's probably just her auntie. But when that white woman came in with a doula, they were educated, they were well informed, they were crunchy granola. Those were the comments that were used. And so I'm a huge, huge fan of doulas being advocates. We can encourage women to be advocates all they want. However, I don't think that me being in labor and my most vulnerable is a time where you should be pushing me to be an advocate. And so we continue to say, let's teach advocacy, let's teach advocacy. That's all great if I'm going in for a high blood pressure appointment or I'm going in for my hemoglobin A1C. But when I'm going in pain and in labor, I don't want to have to fight with you. And so I think doulas in that case are amazing. Community health workers, they build relationships with my patients that I could never build because they're still that you are a provider. You don't, I get a lot from my patients like, you don't know where I came from. I'm like, girl, you don't know where I came from. Don't let these initials fool you. I'm very clear about that, and so while I'm having those conversations with my patients as well and trying to show them, I'm just one paycheck away. Community health workers still are able to get in there and have those conversations with my patients. I never could. And just community as a whole, grandma in our neighborhoods and in our lives are everything, so we're always trying to bring in older women to volunteer, things like that. But the community as a whole, we have to band together and figure this thing out. I said in a talk I did in Ohio, I feel like infant and maternal mortality is the only thing where we are constantly forced to look at trauma porn, right? Aftershock, all of that. While it was amazing and it brought it to light, we constantly ask these families to relive and reopen these wounds daily. But we do that and then we do nothing to help them afterwards, or we are doing nothing on a policy level to make sure things change. And so I think, this is the one thing that we should be throwing the kitchen sink at. And they just throwing a little water on it. And so we as a community have the answers, and we as a community can make it happen.
We don't have any questions from Zoom, but we have praise and
Thank you.
hearts and clapping and all kinds of stuff.
Thank you so much. It's probably everybody I know. Thank you so much. All right, thank you guys.